are occurring in safeguarding across Surrey. This event will be recorded, so if you'd rather not be on camera, please feel free to disable your video. During the session, we'd ask if people can have themselves on mute unless they want to ask a question. The chat will be monitored, and we will pause periodically to answer or respond to any questions. We want this to be as interactive as possible, so we do invite you to share your views and concerns, both in the chat and when appropriate in terms of questions. In terms of attendees and housekeeping, we just ask if you could minimize the use of your camera. That would improve bandwidth, and also have yourself on mute unless you're speaking, which will improve the quality of sound and vision during the session. Please feel free to use the chat box to ask any questions. Vicky will be monitoring the chat box, and at the appropriate time will respond to any questions. As I said, I'm Paul Bailey. I will be joined by a number of members of my team, which will include Maggie Pugh, who is a Partnership Development and Engagement Officer, and also Liz Cassini, who also is a Partnership Development and Engagement Officer. Just to outline the session this morning, of course, you are most welcome. We're going to be talking about escalation, the escalation procedure and the dispute resolution process, and that's going to be led by Maggie Pugh. Then we're going to have a conversation and a presentation around using the Graded Care Profile tool. That's going to be led by Liz Cassini. I'm then going to share with you some learning coming from local child safeguarding practice reviews regarding cumulative harm and neglect. And then I'm also going to share with you some learning that's coming out of a number of rapid reviews that we've had this year regarding adolescent mental health. And then what we will then conclude with is more of a led conversation on working with consent, working in partnership with families with consent. So I hope you find the session engaging, and following the session, of course, you will be given the opportunity to give your feedback. We want you to be as open and as honest as you possibly can, because the aim is to make sure that these events meet your developmental and learning needs going forward. So that's a welcome and introduction. I'm aware that colleagues may be joining us throughout. At this time, I'm going to ask Maggie to start presenting. I will, of course, be using the PowerPoint, and Maggie will be presenting on escalation and dispute resolution. So please welcome with me Maggie Pugh.
Thank you. And welcome everybody. Yes, so my name is Maggie Pugh, and I am a member of the Surrey Safeguarding Children's Partnership team. So what I'm going to talk to you today is about the escalation and dispute resolution process. If I can have the next slide, please. This is what I want to cover. Why we need an escalation process, what the 5 stages of the escalation process are, who you need to contact when raising an escalation, tracking and recording and record keeping, and at the end to give you some key links so that you can find more information about the process and you can find the people you need to contact in order to escalate issues. So next slide, please. So why do we need an escalation process? Well, the purpose of the escalation process is to have a transparent process that sets out how disagreements and disputes between partner agencies can be managed. The aim is to avoid disputes that detract from the focus on the child, that delay effective decision making, and that lead to protracted disputes that negatively impact upon the child and or the family, and particularly on inter-agency relationships as well and working practices. Partners recognise that the complexity of the needs of some children and within some families can lead to disagreements between agencies, as professional judgments, perspectives and experience may differ, and an agreement on the best possible course of action for a child in a family may be difficult to reach as a consequence. There's a wide range of possible interventions and support services that can be provided to children and their families, and so it's not just a case of one size fits all. Often there is no clear right or wrong answer, and quite legitimately, practitioners may exercise their professional judgments differently, and this is where disagreements can arise. Exceptionally, the needs of some young people and families may not easily fit within a conventional application of thresholds. When we experience differences in professional judgments, we need to work these through to make sure that the child and the family concerned are getting the right level of support to meet their needs. And sometimes that will mean bringing other professionals and managers into the discussion. What we don't want is for the child and their family to be caught in the middle of professional disagreements, or to be disadvantaged by any confusion and delays that may result as a consequence of this. These delays can put children at greater risk. When working in a multi-agency environment, it is also not always clear who you need to involve in these disputes, and so this is something that is also made clear within the escalation process. Next slide, please. Now, I appreciate that this is going to be difficult for you to see, so I've already posted a copy of this 5-stage process in the chat, so that if you need to look at it closer, you can open that. So here is a simple flowchart taken from the escalation procedure, which shows the 5 key stages within the process and the timescale set for each stage. As you can see, each stage has a very tight 2-day window, 2 working day window for response. So when a matter is escalated, it requires an immediate response from the agency receiving the escalation. Stage 1 is kept in-house and requires a discussion with your own line manager to make sure that your perspective of the disagreement is appropriate, and to agree together the next action that needs to be taken, if at all. If your manager agrees that the matter should be escalated with the other agency, then you move on to stage 2. Stage 2 starts by identifying the most appropriate person in the other agency to escalate to. Ideally, they should be at the same level of seniority as yourself. A discussion is then had to see if a resolution can be achieved. It is important to note that any correspondence made with the other agency in relation to an escalation should be done in writing so that you have a clear audit trail. It is also good practice to follow up your email with a phone call, if you can, to make sure that the escalation email has been received and that the person you are contacting is not absent and therefore unable to respond. Music somewhere. My recommendation would be to state in the title line of the email what the stage of the escalation is and that urgent response is required, so that it is clear to the person receiving the email that it needs immediate action. After all, the window of time for each stage is only 2 working days. If there's no response after 2 working days, then you move on to stage 3. Stage 3 is where your line manager takes over and makes contact with the line manager of the professional you've been liaising with in the other agency, again to agree a suitable resolution and plan of action. To find out who the appropriate person is in the other agency, you will need to refer to the contacts list, which is posted on the partnership website, and I have a link to that in the final slide. Each partner agency has identified a single point of contact who will be able to help you to identify the name and details of the correct person for you to contact. Once contact has been made, again, there's a 2-day window for them to respond and for a resolution to be achieved. And if this isn't achieved, then it moves on to stage 4. Stage 4 elevates the discussion to the heads of service and director level for each agency. Now, it's important to recognise that some agencies have a more hierarchical structure than others, and there may be a number of management tiers that sit below the director level. But this does not mean that you have to wait and work your way up through each layer of management. For example, if a school is escalating an issue to children's services, then the head teacher may well be involved in the process from as early as stage 1 or 2, and they will still be involved at stage 4. But in children's services, for example, there could be 3 or 4 management tiers that need to be consulted in stage 3. But this should be picked up and managed by the agency that you are escalating to, if this is the case. So there are just 8 working days between the start of stage 1 and the conclusion of stage 4 of the process. So timescales are very tight, but this is done on purpose to drive through a speedy resolution. If after 2 working days no resolution or agreement has been achieved, then the matter is escalated to the partnership, and this is known as stage 5. Next slide, please. It is really important that every stage of the process is completed before the matter is escalated to the partnership, because one of the first things we will ask you is, who have you consulted and what has been the outcome? So it's very important that all discussions and agreements are recorded in some way. There is a special email address for escalating to the partnership, which again is shown on the final slide. And there's also a form that you will need to complete. It's a simple form, but you need to complete that when making an escalation to the partnership. And there's a link to that on the final slide too. We recently had an issue escalated to the partnership which had not been through all the 5 stages of the process. Missing out stages of the process can lead to confusion and unnecessary delays. For example, if a matter is escalated to a director, without it first being discussed with that director's managers, then the director, who's likely to call on their managers for a briefing on the case, will find that they're just not prepared because they've not been consulted. Next slide, please. So when an escalation is submitted to the partnership, and after we have checked that the process has been followed, the following actions are taken. The Partnership Development Manager, which is Paul Bailey, will liaise directly with the relevant agency representatives that sit on the partnership's executive group and will facilitate a discussion. The case may also be further investigated so that a decision can be reached. And the learning from the investigation and from the escalation process will be shared with all the parties, and the agreed actions fed back immediately to the managers involved with the details of the agreements that have been reached. It's very rare for an escalation to reach stage 5, as most disagreements are resolved at an earlier stage. But if and when stage 5 is activated, we do need to understand what has gone wrong earlier in the process that has led it to coming up to the partnership and for the partnership having to be involved. This process has been in place for a year now, so we're currently evaluating the effectiveness of the escalation process and looking at how many issues are being escalated and at what stage they're being resolved. So we've requested a data return from our partners to come to us in January 2022, covering escalations made in the period September to December 2021. So final slide, please. So on this slide, you will find some important links. You'll find a link to the full escalation procedure, which is on the partnership website. There's a link to the escalation form that you will need to use and need to complete if you are going to escalate to stage 5 and escalate to the partnership. And there's also a link to the page that shows you who to contact for assistance in each agency. The person who will identify and put you in touch with the most appropriate manager for the stage you are at. The biggest barrier to overcome in the smooth running of this process is finding the right person to escalate to in each agency. And the most common reason for agencies opting to come straight to stage 5 of the process is because they simply don't know or can't find who to escalate up to in the other agency. So this is why each of our core partners have identified this single point of contact, and you'll find that in the local contact details. Thank you for listening, and if you have any questions, do drop me a line or put them in the chat box and we'll be happy to help. Thank you.
Thank you, Maggie. At this point, are there any questions that have been posted in the chat box or any questions that colleagues would like to ask directly?
Nothing in the chat box at this time, Paul.
Okay. Any questions from the quote unquote floor? Okay, we'll move on. Next, Liz Cassini is going to be talking to us about the use of the Graded Care Profile 2 tool. Please welcome Liz.
Good morning, everybody. Yeah, I'm Liz Cassini, and as Paul said, I'm going to talk to you this morning about neglect and using the Graded Care Profile 2 or GCP2 tool. Next slide, please. So I'm going to start with some facts and figures around neglect. There are over 26,000 children in England on child protection plans due to neglect. In Surrey, almost 2/3 of children on child protection plans due to neglect. That's 630 children approximately. In 2018, Ofsted recommended that all staff should receive training on the assessment of neglect and use specific tools in their direct work with children experiencing neglect. This is exactly what GCP2 does. Neglect features strongly in local child safeguarding practice reviews. And in 2021 so far, there have been 9 rapid reviews where a child has been seriously harmed or killed, and 5 of those had neglect identified. We've undertaken a thematic review of 13 Surrey serious case reviews in 2020. This covered a period of 5 years where neglect, once again, was a key feature. National learning tells us that neglect is consistently a major factor in the lives of children who die or are seriously harmed. Neglect is a feature in 3/4 of serious case reviews. The overall number of contacts where neglect has been recorded as a factor are relatively low on referrals to the CSPAR. We'd expect them to be higher, and that suggests that we're not identifying neglect well enough. So currently, what we're doing isn't good enough. Next slide, please, Paul. We know that neglect is difficult to assess, but using this tool has been proven to help practitioners identify neglect and ultimately improve outcomes for children. We want to have an increased understanding, a common language and a shared narrative of neglect across the partnership. And once again, this is what the tool does. So GCP2 is a licensed tool by the NSPCC, which helps practitioners measure the quality of care that a child is receiving within their family using a graded scale from 1 to 5, where 1 is the best and 5 is not so good. And we've also mapped that against the effective family resilience levels of need. It's a strengths-based tool which highlights strengths within the family, as well as enabling the practitioners to identify neglect and put in place support and interventions to address areas of concern. That means that it's very much based on the relationship that you build with that family. And through highlighting the strengths and the things that the family is doing well, it empowers and engages the family to also seek support for the areas that they're struggling with. The GCP2 reviews what it's like for the child and for us to understand the daily lived experience. It also separates out physical care, care of safety, emotional care, and developmental care. And it's a tool to be used by all agencies for all ages of children. Next slide, please. So neglect is a priority of the Surrey Safeguarding Children Partnership. And to date, we have trained nearly 800 staff including colleagues in family centres, family safeguarding teams, schools, health, family support programmes, targeted youth service, children with disability teams. So it really is covering all partners. We've also run CP chairs bespoke workshops, as well as bespoke workshops for assessment teams and community health therapists. GCP2 assessments are recorded and stored on eSINs, which is a multi-agency platform that can be shared with colleagues across the agencies, and there's also training provided for that as well. There's also a 15-minute e-learning module which quickly helps you understand what's needed and how simple a process it really is to just start uploading. We've given service-specific guidance so that you can include this as part of your daily practice. So we have single agency plans in place for health and children's services currently, and an education one is shortly to follow. That's in development at the moment. Next slide, please. So, to be able to use GCP2, you must be licensed and have attended one of the GCP2 training courses. The course is 1 day long, and these courses can be booked via Olive. I will put all of the links into the chat at the end of this presentation. You may not complete a GCP2 on your own, but many of you are at the very least likely to contribute to a GCP2, especially where a child is on a child protection plan or child in need plan due to neglect. So we really encourage colleagues from schools, health and children's services to attend. Once you are licensed in using GCP2, you've then got access to a variety of support mechanisms, which you can access as little or as much as you need or want to. We know that one of the challenges to embedding GCP2 is practitioners not feeling supported. So we've tried to ensure there's lots of available support in different formats. So this support includes a GCP2 dedicated Teams site, and with nearly 800 practitioners already trained, this is a huge community forum for you to informally ask for tips and advice, maybe help on first time you upload one of the assessments, or simply how to go about it when meeting the families. There are bi-monthly virtual practice sessions to further your GCP2 practice. So these might focus on particular aspects of the tool. So one might be on how to complete the form. There have been other sessions on adolescent neglect, and it really is up to you to feedback on what would be most useful to you. There are champions and practice leads across all areas of the partnership to offer you support and guidance. So again, search those out within your agency, because they'll be only too willing to help you get this underway. A monthly e-bulletin updates you on GCP2 in Surrey, and there's a range of guidance held on the SSCP website. Again, I'll post these into the chat at the end. Information about how GCP2 relates to the service thresholds, and also service-specific guidance, as I mentioned before. There are invitations to attend NSPCC events for all GCP2 practitioners across the country, as there are over 90 local authorities using this tool. There's also refresher training sessions to help you if you're in need of a bit of a reminder about how to use the tool. We're aware that some of you may have been trained quite a while ago, and this is specifically for you to regain that confidence and make a start using the tool. So please make use of these support mechanisms available, and let us know if there are other ways that we can effectively help you make GCP2 part of your practice. And last but by no means least, I've put the GCP2 project manager's contact email there. Alex Darvey is very, very helpful and keen to know if there's anything else that we can do to help you embed GCP2 as part of your practice. Next slide, I think, is just finishing for any questions.
Hi Liz, so we've had one question in the chat and it's from Kate. She says, I've been trained on the GCP2 tool and phoned to refer a child forward as feel neglect is apparently in this family. It was with Sutton. They have suggested early help, which we feel we're already doing. Suggestion, please, do we need to escalate this? So this kind of comes in with Maggie as well.
Referred a child forward, doesn't it? Okay.
Liz, can I respond? Is that okay?
Yes, you may.
So in terms of your use of the tool, one of the questions I would ask is, what is it telling you? What is the grading of the state of neglect? What is the scoring? And does that indicate that actually you're looking at concerning levels? The other thing as well is in your referral or request for support, what exactly is needed to keep the child safe? What are you seeing? What are you hearing? What are you smelling in terms of what's going on for that child and their lived experience? And then thinking about the impact of that on the child. So for example, if the child is coming into school tired, they're not learning, and that's having a developmental impact. Or if the child's coming into school hungry and asking other pupils or for food or so on, or if the child's coming into school smelly and disheveled, and that's impacting on their social interaction with other children, for example, being subject to bullying and so on and so forth. It really is about what's the evidence base for your concern, and being able to have a conversation either with colleagues in Sutton or Sutton Children's Social Care or others to say, actually, this is what we think is needed. This is what we think will make the difference, and engaging in that consultative conversation about what will help the family. I hope that's helpful.
Thank you, Paul. Yes, I would say that it's a grade 4-5, so quite concerned in certain areas, not every area. It's a 4-5, but because we don't normally deal with Sutton, it just is the child has lives in Sutton but comes to a school in Surrey, so we're trying to work with them and us, so I don't have necessarily the same relationship with them, but we're concerned with what is going on at home more than what's happening in school, and connection between adults and the child, because it doesn't seem to be much of a response from parent with child. So I feel that I need to sort of escalate it slightly because I'm concerned of what is going on at home. But it's just working with a different partnership that I'm used to, that is
Sure.
just slightly different.
Sure. Do they have a consultation line in their?
I would have to check. We've directly with some of them, but I will check if they do.
Because it would be helpful to actually have a consultation. So you've made a referral, but
yeah,
have a consultation with somebody in, I think they have a MASH rather than a C-SPAR. Have a consultation with someone in their MASH, sharing with them exactly what you're concerned about. And can I ask, have you sought consent from the family in terms of information sharing? Brilliant. And you've got consent. Fantastic. Yeah. So in which case there shouldn't be an issue with you saying these are the things that you're really concerned about. These are the things that you're really worried about. And if you can really demonstrate the impact on the child, on their well-being. So if you think about neglect, it's about persistence, and it's about pervasiveness. So how often is it happening in the life of the child? And then how pervasive is it? How is it impacting the child, you know, in terms of their learning, their relationship, their speech and language, their self-esteem, all of those kind of things. And if the more you can share that with them, what you're doing is providing evidence of the impact of the lack of care.
Thank you. I don't want to take over, but thank you.
No worries. I hope that's helpful.
Thank you. Yes.
Were there any other questions? Sorry, I jumped in on that one, Liz. Sorry.
That's fine.
No further questions in the chat, Paul.
No worries. I'm going to move on to the next side or subject, and I want to talk about cumulative harm. So this has come up in a number of our rapid reviews. As Liz said, we had 9 rapid reviews this year, and a significant number of those rapid reviews, at least 50%, include a history that would highlight cumulative harm. And when I say cumulative harm, the definition that I'm working with is a accumulation of a single adverse circumstance or event, or alternatively, multiple different circumstances and event. And what we're thinking about is the unremitting daily impact of these experiences on a child, which can be profound, exponential, and can diminish a child's sense of safety, stability, and well-being. And so we're thinking about harm over time. And related to the understanding of cumulative harm are 2 errors in thinking when it comes to our practice. One has to do with the rule of optimism. And that so we come into a situation and we're really hoping for the best. And in hoping for the best, we then take any sign of improvement, whether or not it's sustained, to say, actually, things are getting better, we can step out. Cumulative harm really counters that thinking by forcing us to think about what does this accumulation of adverse experiences, adverse circumstances and events mean for the well-being of the child. And the second error of thinking is what we call the start again syndrome. And this is when a new worker comes in or there's been a new referral, and instead of thinking and looking back at the history of what's been happening for this child and in the life of this family, we start all over again as if it's a fresh referral. And it's so important that as agencies, and it's not just social care, it's all agencies across the board, that we live with the adage that the best indicator of future harm is past harm, that history of family functioning is really, really important. And so we need to really understand how families have lived and worked together.
Event.
Hello, someone speaking? Colleagues can ask if we could be on mute unless you have a question that you'd like to ask. All right, so cumulative harm and emotional abuse and neglect. So thinking about cumulative harm, emotional neglect is similar to emotional abuse in that they both constitute the air in which some children have to breathe and the climate they have to live in. So if you think about a child's lived experience, the persistent, unremitting lack of care that a child has to deal with every day. And so a child who experiences emotional abuse and neglect, they become really, really tolerant of a lack of care. And we're not thinking about the isolated events, because what we find in our child protection processes is that we're often very, very disclosure driven and event driven. So a child says that they've been hit, they've been spanked, they've been touched inappropriately, or they've been emotionally, physically, or sexually abused, and that disclosure then triggers us into action. Alternatively, a child falls from a window or harms themselves or comes up with a bruise or drinks a substance or playing with dangerous equipment like a kettle or a knife, and they're hurt, and then we move into high gear and action. And what we are not always attentive to as a system is what is it like on an ongoing basis. I'm thinking of a case that we recently reviewed, and this case had a adult mental health worker going into the family several times a week. It had a substance misuse worker going in to the home, and it also had a parenting support worker going into the home. This was a 24-year-old mother with a child who was an infant under a year old. And it was when mom called the ambulance that the ambulance service, when they came into the home, they looked at the state of the home. They found it hard to access the kitchen because of the pile up of dirt, of rubbish. Food was left uncovered. There were fruit flies flying around. The home stank. When they went into the room where the baby slept, the cot was full of clothes, and it was really a state. And as a result of that, they made a referral in to children's services, and the child was then taken into care and looked after. The question that I have is, what were the other workers who were going into the house seeing, hearing, smelling, and feeling when they were going into the home? And it's so important that we think about the lived experience of children. Going on to the second aspect of this, the emotional neglect and abuse often appear to constitute a persistent background. So the highlighted words, the air that children have to breathe, and this persistent background in which they live, tuned into the lived experiences of children. So thinking about cumulative harm, we have to ask the impact question. A accumulation of adversities can continue into adult life. The case that I just referenced, this person at the age of 24, they were a care leaver themselves. Their mother had substance misuse issues. They were in a violent relationship. They were using substances. They had their own mental health concerns. And what we can see is that child had what we call ACEs, or adverse childhood experiences, which then led to a range of adult vulnerabilities. And that point is made in the next bullet. Many parents of neglected children are also suffering from the effects of cumulative harm. And if you think about neglect, and you think about the cumulative impact of neglect, if a child routinely is not properly fed, not taken to the doctors, not properly clothed, not bathed, what does that do to the child's sense of their self? What does it do to their sense of being special? Their sense of having somebody who dotes on them, who's genuinely crazy about them in a positive, loving, nurturing, consistent way. And we have to think about that and the cumulative impact of that. Accumulation of factors will also elevate the likelihood of a child suffering neglect. So if we think about cumulative harm, what helps in terms of our practice? And how can we get better? I think the use of chronologies, and I know this is very much used in children's social care, but I've seen multi-agency partners in education, in targeted youth support teams, in parenting services, in voluntary and community organizations use chronologies and family histories that give a pattern that evidence consistency or inconsistencies in care over time. Having a trauma-informed, evidence-based assessment of the child and the family's lived experience. So our colleague who talked about the referral that they are attempting to make to Sutton, if they can convey in that, what is it like for this child coming into school? I remember there was a family that we were working with, and in which this child was neglected. The child sadly stank because they were not washed, their clothes were not changed, and the parent wasn't getting it. We were trying to share the assessment with the parent, and the parent felt that we were attacking them and we weren't understanding their experience as opposed to the child's experience. And so one of the workers invited the parent to visit the school at playtime, and the parent visited the school at playtime unbeknownst to her child and looked out at the playground with the child with what felt like an invisible bubble around her where nobody would play with this child. And the parent said, "What's wrong? Why is nobody playing with my child, my daughter? Why is nobody playing with my child?" And the worker said, "It's because they call your child smelly. They don't see your child as being washed and clean, and nobody wants to play." That's the impact. That's the lived experience for the child. And I have to say that was the turnaround in that case. The parent immediately tuned into the need of the child and made the connection of the child being clean, rested, fed, turning up to school in a place where they were ready to learn. Asking what the life is like for the child and listening to those who know the family. Sometimes when I speak, colleagues may feel I have a bias towards schools, but it's because schools work with families. They see children Monday, Tuesday, Wednesday, Thursday, Friday for several hours during each day, about 5 or 6 hours each day. Many schools, particularly primary schools, will know not only the parents, but they will know cousins, uncles. They will also know grandparents. That in some cases, you have some teachers who have taught children and parents, several generations of the family. They have a really good understanding of the lived experience of children, but also patterns of care within families. So it's so important that we are attentive to what schools are telling us when they have a concern. The challenge for schools and early year settings is that you're able to translate your concerns into actionable evidence. The other thing to say, and I think it's an important thing to say when you are making referrals or having consultations with colleagues in children's social care, is that, you know, we don't operate within children's safeguarding on the basis of beyond reasonable doubt. We operate on the balance of probability, and with neglect, it is the persistent failure which is likely to. And so what we're asking is about what is the likelihood of harm, and what's the scale saying? So it's a matter of professional judgment. It is a balancing act, but it's us thinking through what is the likelihood. So that is on cumulative harm. Any questions in the chat, Vicky?
Nothing in the chat.
Comments? Okay. Any comments from colleagues?
Can I ask a question?
Please.
Yeah. We've recently referred a case in because we feel that risk is very high, but the problem we have is we're struggling. The initial assessment weren't done in the actual child's home, and we're very much thinking about what is the child like every day, what's the child's life like every day, and we think there's a serious case of risk there, but the communication that we're getting back as we're going through the escalation process is all via email, and then it's not very prompt, and the last one we got actually said, I'll try and assess in the home, but I'm leaving in 2 weeks.
Okay, that is an issue, isn't it? Because part of the assessment, if you think about the assessment triangle, is the home environment. And so I would certainly escalate that. You can't have an assessment of a child that is not based in the home. I can share with you an experience I had with somebody in my team that was supposed to be working with the family, and there was real concern about domestic abuse, quite severe domestic abuse. So for example, one of the incidents was this man took a 50-inch television and battered his partner with that TV. And so there's a high level of risk, and we're really concerned. A newborn child was about 6 to 7 months, and a 7-year-old boy in the family. And the member of my team was charmed by the man. And I have to say, and I'm not saying there's an inappropriate relationship, but what we have to understand about people who are violent in relationships, who use coercive control, is that they do not only charm the victims, they also charm networks that would support victims. And I'm using the word charm as a verb, incredibly charming. And then convince this worker to have meetings outside of the family home. We had a team around the family meeting. That team around the family meeting, I noticed that the man had a cut on his hand, quite a deep cut, and had gone to hospital. And I asked, how did you get the cut? And he said, oh, I was cutting chicken, and I was cutting chicken and I cut myself. And then thankfully we had a conversation with the child. And the child told us that mum and dad had a fight. Dad was trying to beat my mum. Mum threw a plate at dad and then used a knife to defend herself and cut dad quite deeply. All of this was going on while the worker was meeting with the father in the family outside of the family home. Had we been in the family home, we would have gotten the sense of the conditions in the home. So to support your point, it is so important that assessments include going into the home, seeing the child's room, seeing the state of the home. So important. I don't think you can do an assessment. So I would encourage that escalation.
Yeah, but we have escalated it and we've not had a reply from the manager. So now I've gone to the service manager, right, and we've not had a reply.
What I would do, I would get their contact number and try and have a conversation with them. I'm not saying it's easy because, of course, if you're dealing with social work team managers and others, it can sometimes be difficult. But please, quality of assessment is something that comes up in rapid reviews, local child safeguarding practice reviews, and before that, serious case reviews. The child has to be seen, the home has to be seen. So my encouragement to you is please, don't stop in the escalation, and of course, move it through the stages if you're not getting the response you need.
No, we will do. We will do. I just wondered if there's anything else that we could do, because I totally agree that until you've seen that home and the environment that the child's living in, and you see the mum on their own with the child, as opposed to bringing a friend in or a relative with them, it's a totally different assessment.
Yeah, absolutely.
Thank you.
No worries. I hope that's helpful. Okay, so I spoke a little bit about learning from rapid reviews. As we've mentioned already, we've had 9 rapid reviews so far this year. A significant feature of our rapid reviews have been adolescent mental health. Out of those 9 rapid reviews, 4 have been child and adolescent suicides, in which young people have sadly taken their lives. And then we've also had 2 where young people have attempted to take their lives. So self-harm is really significant. Here's some factors that it's so important that we are aware of. This comes from the National Child Mortality Database, who produced a report in October 2021. So this is relatively new in terms of the report. And it's based on child deaths in England from the 1st of April 2019 to the 31st of March 2020. So it looks at if you want, a working year, financial year, business year of the cases. And what they have identified is the factors related to child and adolescent mental health. So one of them is household functioning. That goes to the point we've just been talking about, how a family works, how a house works. So if there are challenges in family functioning, relationships aren't working, there's a breakdown in the relationship between parents and so on. They're not good routines because of mental health or because of parental illness, which makes the child or children young carers. How the house works. The loss of key relationships, that could be relationships with a boyfriend, a very dear friend, even a pet can impact emotional well-being, mental health, but grandparents, so loss of key relationships. Another factor has to do with the mental health needs of the child. So a child expressing sadness, self-harm, suicidal ideation. A 4th factor has to do with risk-taking behavior. And adolescence, we know, which is from, and the way I'm understanding adolescence for the purposes of this conversation, is adolescence ranges from around 9, 10, going up to 18, 19. Okay, if you that broad period when a young person is making the transition from childhood to young adulthood. Risk-taking behavior is part of adolescence, but risk-taking behavior in the context of emotional and mental distress. Conflict with key relationships, so parent-child conflict. And this goes beyond the normal teen door slamming and I hate you and you know, that sort of thing that, you know, we all will experience from time to time as our children get older and seek to individuate from us. But this is where we're having significant conflict that is ongoing and that is impacting on the functioning within the home. Issues with service provision. So this might be child and adolescent mental health services. This might have to do with access to health care, access to appropriate education. Education comes up in a little while. Problems with service provision, parenting support, youth support, diagnosis of need. The context of abuse and neglect, very, very important. So this is why how it relates to the issues of neglect and cumulative harm. Problems at school. And when we talk about problems at schools, we could be talking about bullying. We could also be talking about, which is another factor, neurodevelopmental conditions, things like ASD or attention deficit hyperactivity disorder, ASD meaning autistic spectrum disorder, or a range of other social communication disorders, curriculum challenges, relationships within schools, or possibly sexual abuse, harassment within schools, criminal exploitation that could occur in and around schools. Problems in school can be a risk factor. We've identified bullying, medical conditions within the child, substance misuse and alcohol misuse within the family, but also more particularly by the child. Social media use, and by this I mean problematic social media use. There's nobody who doesn't use social media today. Most of us are in some way or other involved in social media, but it becomes problematic when young people are using social media in a way that is excessive, the type and quality of the sites they are accessing. So sites that access and talk about means and methods of self-harm and things like eating disorders and promoting a certain type of body image and impacting on self-esteem. We already cited neurological and neurodevelopmental factors. Sexual orientation, identity, and gender identity. This has come up in, I think, 3 of our rapid reviews this year, where young people, and of course there is a published report, unpublished report of a case review where a young person had gender identity issues. Sadly, they took their lives. So it's a significant issue, particularly if parents aren't either sympathetic or understanding of the child's sexual orientation or gender identity. So when you think about faith-based judgments or prejudices about sexual orientation and sexuality, how that impacts on child safety and well-being. Problems with the law. So in about 2 of the rapid reviews, there were problems, 3 of the rapid reviews, there were problems with the law included also. So what else are we learning about child and adolescent mental health when it comes to our rapid reviews? Number 1, the need to include CAMS in child protection processes. Sorry, it says child protections processes. It should be child protection processes. And this is so important. And I think it's a 2-way street. Not only is it about inviting CAMS, it's about CAMS being present. So there is a challenge that we have to ensure that CAMS are involved in child protection conferences, both initial and review conferences as appropriate, that CAMS are involved in core groups, and then also the need to include CAMS in early help and targeted youth support, particularly around team around family meetings. And the reason why this is important is because CAMS will have an understanding of the nature and the extent of the child's mental health. They will also have a different appreciation of what is risky and what is not. That contextual information is essential if we are to formulate an effective plan to support the child and their family. We need to have the expert around mental health in the room when we're planning care and support. The need for schools to share information and make referrals for support where there are concerns. Now, this is quite interesting because we've had colleagues in schools who are trying to make referrals. But what we found is that there were some schools who were supporting a child and their family without necessarily making a referral to children's services. And when you have an instance of self-harm or repeated incidents of self-harm, and suicide attempts, it is important to seek consent and share information appropriately. Where you have severe suicidal attempts and severe self-harm, you may be able to override consent to make a referral. But we work on the basis of consent, and we are encouraging schools to share information with consent. What type of information do you need to share? Information about the child's mental health and emotional well-being, information about how the family is functioning, how are they working together, their understanding of the child's, if for example, if the child has a neurodevelopmental need, how is the family coping with that? How are they dealing with the loss of an ideal child in the event of a diagnosis of something like ASD or ADHD. Understanding ASD is a spectrum from high functioning to more severe, and how does that show up in the child's life? Incidence and severity of self-harm, incidence and severity of suicidal ideation. And what we're encouraging colleagues to think about in terms of sharing information is who needs to know and why they need to know. Think about who knows and who needs to know. Always seek consent if it is safe to do so. When we say if it is safe to do so, that is, there are some instances where if you seek consent, it will put the child at additional risk. Those instances are particularly rare, but in most cases, we would expect colleagues to seek to share information with consent. My own value base on this is that when it comes to working with children and families, we ought to do naught about them without them, nothing about them without them. I believe that children and families are senior partners in the safeguarding process. And so it's so important that we think carefully and clearly about how they are included, how we can use the wisdom, the experience and the knowledge of the family, and we do that by getting better at working less with coercion and control, i.e. you have to work with us or we take your children away, and more partnership. What's the situation? What's going on for you? What would be helpful? What works for you? What does a good day look like for you? How can we have more of that? Working on the basis of partnership. And I think things like motivational interviewing helps. Things like solution focus helps. Things like coming from a strength-based place helps, whilst not underestimating the risk to children within families. I'm going to pause at this point for any questions, and then we'll go into the conversation around consent.
Hi, Paul. Again, no questions in the chat.
Okay. Any questions from the floor or any views or issues? Okay. So I've indicated the need to kind of share information and to work with consent. And this can be a tricky issue. And what we found, and the Child Safeguarding Practice Review Panel, also known as the National Panel, in their annual report, they said there are some examples of good information sharing in the reviews, but unfortunately there are many more where sharing is still patchy or not taking place at all. And I have to say that has been our experience in thinking through what's happening in our own local child safeguarding practice reviews and our rapid reviews. The timely and effective sharing of information. Multi-agency safeguarding hubs, SSCPRs, are designed to facilitate the sharing of information. But in 8 reviews found in the Child Safeguarding Practice Review annual report, there were specific concerns about how information was shared or not shared within SSCPRs or MASHs. Okay, why is it important? One of the things that I always think about is we don't have individually as agencies a full view of a family. We have a partial view. So if, let's say, for example, I'm a GP, I only see them within the window of them coming into surgery around specific health needs. If I'm a minister or a imam in a mosque, I only see them as they come for Friday prayers, or they come for Sunday services, or if they are Jewish, as they come for services at the synagogue. I only see them within that context. Schools only see the children, but have fleeting contact in some cases with parents as they collect or drop off children, or if they attend different meetings at school. But it's how we hold families and children together. Information sharing is like 4 blind people holding an elephant at different parts. Someone's got the ear, someone's got the leg, someone's got the torso, another person's got the trunk. And it's together as we describe what we're feeling, what we are sensing, what we are experiencing of the family, that we have a full view, if I can work with that analogy. So the importance of effective information sharing and communication between practitioners and agencies is the most frequently cited category when local safeguarding boards, as then respondents, were asked to identify the main topics to emerge from serious case reviews. Okay, effective information sharing. This comes from the triennial analysis of serious case reviews, is one of the most basic tenets of good child protection practices, and is one of those lessons that is so important that it must be re-emphasized and potentially relearned as people and organization and cultures change. It's so important that we have that. We are encouraging, this is from Working Together 2018, and we're encouraging us to have a proactive approach. When I say us, agencies, our system, to have a proactive approach to sharing information. Fears about sharing information must not be allowed to stand in the way of the need to promote the welfare and protect the safety of children, which has to be the paramount concern. That is also enshrined in the Children's Act 2004. And the Children's Act 1989. We really do need to think about how we can proactively share information as opposed to, oh, I can't share. And we need to think about how we do that effectively. So how can we move towards this? This comes from the Surrey Effective Family Resilience model, which is our threshold document, our levels of need document. And what it says, information should be shared in the spirit of openness and transparency and honesty between practitioners, the child, and their family. However, it is important that you have due regard for the principles of confidentiality and parental consent. Now, here's the thing for us, and this is why I wanted to kind of raise this session, is that we have got to move beyond tick box consent and move to a place where we are working with families in a spirit of transparency and openness, where we get better at having consent conversations with families so that we become consent workers to some extent. And what do I mean by that? Anytime you work with a family, it works best when they are motivated to get involved, when they understand and there's a shared understanding of the concerns that you have, and that they are part of the ongoing plan of support. When families have high levels of motivation and they have high levels of commitment, any change in that family is likely to be sustained by the family after services withdraw. Where families are coerced, what you sometimes get is disguised compliance, where families comply enough to get you out of their space and face, And once you leave, families revert back to type, whether that type is healthy or not. What we want is families that recognize what is harmful, what is worrying, why we are concerned. They see what we see what they see, and we work together on forming a joint plan of support. That only happens when we work together on the basis of consent, because we recognize the autonomy of families. While I'm on this point, one of the things that we have seen across our safeguarding system is that issues of class, affluence, and influence impact how we work with families. So if you have a family from, and I'm going to be very general here, I'm very stereotypical, from the local estate, what happens is we tend to be much more authoritative and much more coercive. But if we have a family from the 5-bedroom leafy mansion in one of the posher areas of town, dad's a barrister, mum is a corporate executive, to be heteronormative, and within that family. So we tend to tread quite softly around the family. And if the family say no, we back off very quickly. And what I think we need to do is work on the basis of consent with everybody we work with. So whether or not, regardless of the family's social class, we don't up our ante in terms of being coercive, but actually we work on the basis of securing consent with families. So this again is from Working Together 2018. Wherever possible, you should seek consent and be open and honest from the very outset as to why, what, how, and with whom the information will be shared. Should seek consent where an individual may not expect their information to be shared, to be passed on. When you gain consent to share information, it should be explicit and it should be freely given. There may be some circumstances where it might not be appropriate to seek consent because the individual A cannot give consent, or it is unreasonable to obtain or consent, or alternatively to consent to seek consent would place the child at additional risk. Those instances are rare. In most of what we do, consent can be sought and it can be gained, provided we are skilled at engaging with families. Do we take the time? And sometimes it takes a number of goes. So the first time you ask, the family might say no, but then being persistent and coming back and saying, look, we're still a bit worried. You said no the last time. Have you had any time to think about it? Because here's what we want to do. Here's what and being honest about what the goals are. Yeah, we're not trying to interfere and intervene in your life. We want you to get the support you need. And then coming back again, when families see that you are persistent and you are committed, you're coming from a place of empathetic and authoritative practice, not authoritarian practice, but authority. You're standing within the strength of your role as a practitioner, and you're sharing with the family honestly and openly what your concerns are, demonstrating to them the evidence, securing consent over time. And when a child is at risk of immediate harm, you have to trump consent, whether you have consent or not. But when you are worried about a child and it's not yet at that place of risk of immediate harm or evidence of a harm, you use the time to build the relationship and seek consent with the family. Okay, so some practice issues. One of the things that colleagues are worried about is the relationship, the ongoing relationship with service users. Oftentimes, this is a legitimate worry. However, if we, as I've suggested, focus at the very beginning that there may be times when we might want to make referrals and we will seek your consent. If they know that from the outset and they understand why, actually the concerns about relationship can be resolved. A relationship can survive a referral and actually can improve, the relationship can improve. Another issue has to do with practitioner confidence in seeking and securing consent. And one of the things that we will be working on is a package of briefing and support around consent work, working with consent and developing consent. Confusion around when consent is needed. And in most instances, you will need some level of consent. However, if there is a clear and present safeguarding concern, in other words, a child is at risk of significant harm, or a child has experienced significant harm, the consent can be overridden. So I've already talked about insufficient practice guidance and tools to support consent work with families. And the challenge is, how can we all within our system become skilled at being consent workers? I'm going to pause for a quick second to respond to any questions or issues that you might have as a result of what I've just discussed or shared.
I've got a question, please.
Please.
My name's Sharon from the Runnymede Family Centre. I think I'm speaking on behalf of my team. I've listened to what you said, some really good points. We're working with families at level 3, but fairly often we're having a lot of families with parental conflict having a negative impact on the children, and we're having one parent happy to engage but saying only if it's just me, not if my other half's involved.
Right.
And what do we do with this is my question.
Shannon, it's a brilliant question, and it feels like we've both been impaled on the horns of a bit of a dilemma. I would take a very pragmatic approach, a very child-centered pragmatic approach. So if the parents are in conflict, so sometimes they're living in the same home, okay, that is really problematic. If they're living in different homes, problematic but less so. I would go with the consent that you've got. So if you've got consent by one parent, you operate on the basis of that consent.
Yeah.
And then in conversation with the service or the agency that you're referring to, have a conversation about how the intervention will be managed, bearing in mind the express wishes of the person you've sought consent with. There is clearly more work to be done so that both parents are on the same page. But sometimes what we find in some instances, partners get so enmeshed in their conflict with each other that they can't see anything else. And part of the challenge is to get them to see the child's experience and understand. And it's really, really tricky. But I do think my advice would be, one, to go with the consent you have. Work with the agency that you're referring to, recognizing there is a need to do further work to make sure that both parents who are involved in the child's life have the same view and are working to the same plan. That might become part of the plan of work with the family.
Thank you. Yeah, it's a very difficult one.
It is, it really is. And also the other thing to bear in mind, I do need to say something else actually on this. When you're dealing with the context of domestic abuse, so there may be a situation where ideally you would work with both parents. But when you have somebody who is the victim of domestic abuse and you've got consent from them, and they are saying, I cannot work with the father or the other partner because of domestic abuse, we have to be attentive to that. Because what we do know, when you're dealing with families where there is coercive control and there is domestic abuse, oftentimes children are used as a means of coercing and controlling the other partner. And so it's important that services are attentive to that. The other thing as well is when a person is exiting a relationship where there has been domestic abuse, that places that partner and the children at a higher level of risk. Okay. Any other questions?
Nothing in the chat, Paul.
No worries. Well, I'm going to stop sharing. I've got one last slide to share, and this is about our priorities. So our priorities really are around early help and thresholds of need that we get in early, and that instead of having conversations around whether or not things meet thresholds, we're really having more conversations about what is the need. The second thing has to do with, and you'll see why in terms of the presentation this morning, child and adolescent resilience and support, mental health, safety and well-being in online spaces, Contextual safeguarding, that means safeguarding children as they move away from the family and the home. Sometimes it's not the parents, but it's the company and the places that our children, the company our children keep and the places that our children hang out at that is posing a risk. And then safeguarding children with additional needs, including those with special educational needs. And then thirdly, the third priority has to do with neglect. And you'll see that has been, all of those issues have to some extent been a theme that's run through. I'm going to stop sharing so we can see each other. I really hope that's the end of our presentation today, and I'm really happy that you've got an additional 16 minutes back in your day. I'm going to try and stop speaking so that we stick to that, and it stays at about 15 minutes left for you to maybe have a coffee before your next thing. But I hope it has been helpful to you. I hope that these sessions support your learning, your development, and that you can share. A couple of things going forward and thinking about our next steps. After the event, we will be sending the presentation through to you via email. So you will have a copy of that. Please use the link in the feedback, the link in the chat to give us feedback. We want to get better at this. And if there are particular topics you'd like us to brief on, it would be really, really helpful. An email will come out to you thanking you for your attendance, but also giving you some additional information. Our next briefing is planned for the 3rd of March, 2022. So again, it will be a morning and an afternoon session, the same briefing given twice to allow for a greater opportunity to attend. Thank you so much for your attendance. Have a great day. And thank